Good morning, everybody.
Hi, Karen. Thanks for logging in.
No problem. No problem. I'm sorry. I didn't realize until like this last second that I didn't actually have a link. So,
Yeah.
All right. I'm going to go mute. You guys go ahead and have a good talk.
Yeah, the transcripts and everything. Oh. Yeah.
Well, I'd rather stand up there.
So let's let Anthony. Oh, you want? Okay.
Well, I mean, he won't know when to advance the slides.
Yeah.
So, no, and we're sharing the screen, it's pulled up and we're recording, so you're good to go whenever.
So I'm one of recording this and putting this on Canvas.
But yeah. I'm just curious.
I don't know how many people are logged in at the moment. Just 7 are logged in right now, and then there's the 4 of us. More coming on.
Well, here's what's going to happen. I'll start where you are, and we end up having to stand up. I can't hear anybody.
Is the meeting on? Can you guys hear us? Or muted, it sounds like.
I'm muted, that's about it.
Ellen responded that you can hear us.
Okay, yes, I can hear. Okay. Okay, great. Everything. Thank you, Dr. Carpenter, for coming.
Can everybody hear me? We're going to go through a lot of stuff today. I apologize. It's kind of action-packed. I want to tell each of you ahead of time that I anticipate a lot of questions. Okay, this is our opportunity to have free-flowing conversation about how to manage atrial fibrillation. And I'll give you a spoiler alert. The way we manage atrial fibrillation has changed a lot, and it has changed rapidly, and it will continue to change. So if we were to give this talk next year, it would probably be a different talk. And it's a different talk than I used to give several years ago. It is really okay for anybody. In fact, I would prefer it. Anybody out there has questions, raise your hand. I don't have access to the chat, but you guys do, right?
Yes, you can look at the chat.
Okay. So raise your hand, have something in the chat, and we'll go through it. Our goals here are to talk about atrial fibrillation. We don't have to get through a set number of slides. Okay, so I'm going to start out right away. And this is a little bit different talk than I have given before. I usually give it for either inpatients or outpatients. You guys take care of both. So I'm going to talk in broad strokes. So when people, a lot of times people will come up to me often at family gatherings and say, I have atrial fibrillation. What should I do? And the answer is, I don't know. The answer is, I don't know. And so a lot of things go into our consideration of how best to take care of somebody. And those considerations include whether or not they have thyroid disease, structural heart disease, hypertension, diabetes, a previous stroke, what their symptoms are, what their functional status is, and especially their age. This is a slide that should scare each and every one of you. So this is supposedly the boomers heading towards atrial fibrillation age. To me, it looks like a tsunami, and it's headed right towards Fukushima. Okay, and notice that that's in 1995. Okay, so another slide illustrates this, and that is, if you're wondering why we're seeing more and more people with atrial fibrillation, it's because more and more people are having atrial fibrillation, and that's it's hard to see that slide, but that's only over the past 12 years. That's how much it's increased. So whether we enjoy taking care of atrial fibrillation or not, it's here with us to say. Fortunately, this is the best time, I'll say it again, this is the best time to have atrial fibrillation. We have a lot more options and a lot more knowledge about how best to treat it. So when we go through the diagnostic evaluation, of course, we're going to do a history and a physical exam. Both of those are going to end up being really important. I can often figure out what to do if I lay eyes on a patient and I've read their history. You cannot take care of atrial fibrillation without an echocardiogram. Okay, and anybody, why do we check thyroid function tests? It's scary, right? Because you can't reach an endocrinologist. So I don't know if I should order them. Why do we order them? All right.
We have to still with there.
Okay, no, it's okay. This is not Jeopardy, I apologize. So it turns out that atrial fibrillation can be the first and only manifestation of severe hyperthyroidism, okay? So everybody who develops new atrial fibrillation needs to have thyroid function test study. The likelihood that you will uncover severe hypothyroidism is low. Eventually you'll miss it. Okay, and then you'll be treating the wrong disease. And yes, I think a sleep study should be part of the evaluation. I'm fine if it turns out they don't have sleep apnea. But if you're treating atrial fibrillation without treating obstructive sleep apnea, in a lot of ways you're handcuffed. So this is a slide I don't like. This is a slide that you will see in every textbook of medicine. They'll talk about, they don't use the quotation marks that I do. Primary causes of atrial fibrillation: hyperthyroidism, dilated cardiomyopathy, valvular heart disease, sleep apnea, and then it co-migrates with coronary disease and hypertension. I don't like the term primary because it is not true that if you get rid of the quote primary cause, that atrial fibrillation will go away. In fact, in general, those people will still have atrial fibrillation, even if they get their thyroid treated. Those people, and I cannot prove this, but I firmly believe this, those people in whom atrial fibrillation is the first manifestation of hyperthyroidism are much more likely to have atrial fibrillation throughout their lives than people who don't. Likewise, you can treat sleep apnea and they will feel better and they'll have less atrial fibrillation. It doesn't cure it. So what are our goals of therapy? This part's, if I don't like to give handouts, I used to take handouts all the time when I was training, and they're still in my file drawer. So they don't help me that much, but if I were to give a handout, this is the one I'd give, okay? Our goals of therapy are manifold. We want to reassure them. We need to give them a dose of reality. We want to prevent strokes. We want to control their symptoms. We need to control their rate, and we'd like to maintain sinus rhythms. Okay. So the first thing we do is we reassure them. In general, if you are the first responder, and this could be in the office or it could be in the hospital, patients come in with atrial fibrillation, they tend to be unhappy. They tend to be scared. They tend to be worried and miserable, and often it comes out as anger. I don't know how that happens, but So you tell them ahead of time, atrial fibrillation is not a lethal problem. Secondly, it's not necessarily a sign of worst form of heart disease. Millions of Americans live normal lives with atrial fibrillation. And we can treat you effectively. We can treat you effectively. If there's one disease that we have a lot of experience with, it's atrial fibrillation. The reality is that atrial fibrillation is forever. If I had $1 for everybody who walked into my office and said, Carpenter, I'm done with this atrial fibrillation. Get rid of it so I can get on with my life. Well, I would have retired, okay? And we really, and the very first time we meet them, patients need to know that, yes, we can get you back on track. Yes, we can ameliorate your symptoms. We don't have a cure for atrial fibrillation. We have very effective therapies. And from bitter experience, I can tell you, if patients don't learn that early on, they will set themselves up for bitter disappointment, and they'll usually switch to care providers. Okay, so this is the most famous guy I know in Maine who had permanent atrial fibrillation. And he's got a great story, which I often tell patients about. He had his first episode of atrial fibrillation in 1991 during the invasion of Kuwait. And he quickly progressed to permanent atrial fibrillation. And I know exactly what you guys are thinking. Those dumb doctors in Kennebuck didn't have the right pills. I assume he had access to adequate medical care. But that is the nature of atrial fibrillation, and it certainly was the mainstay of therapy in 1991 was rate control. Now, for the next 3 decades, he jumped out of planes, circumnavigated the globe, was an elder statesman, and cut ribbons. But he lived a healthy life, and he was in atrial fibrillation the entire time. Let's talk about symptoms. Symptoms are frequently both over and under attributed to atrial fibrillation, and I will go through this with you. But I do want this to be interactive. So sometimes people over attribute symptoms to atrial fibrillation. They say, this is all because of my atrial fibrillation. And I'd like to hear from you guys, what sort of things can make you feel bad, but it's not your atrial fibrillation? I almost heard somebody.
Heart failure.
Heart failure, that's a good one. So one of the major reasons people feel bad in atrial fibrillation is not because they're in atrial fibrillation, it's because their heart rate is 130. So that's important. So if you tell them, I'm going to get your heart rate under control, that you'll still be in atrial fibrillation, they should not be upset. You should tell them, I'm going to make you feel better. Patients do get heart failure. They get heart failure for several reasons. Elderly people especially, but even younger people can develop heart failure with rapid ventricular race, even with preserved LV systolic function. And tachycardia-mediated myopathy is very common. And we'll talk about that a little bit more. The other ones are things that we really do need to address head on. And that is that there are a lot of reasons people don't feel so good. They can be older, they can be out of shape, and they can be above their ideal body weight. And one of the leaders in AFib ablation used to say, and I'm only going to say this in the room, the door is open, but I don't think anybody can hear me. He said, I can ablate your atrial fibrillation, but you'll still be middle-aged and fat and overweight and out of shape. Okay. And so we're never going to say that. But at the same token, we do need to explain to them that an ablation or some other way of restoring sinus rhythm will not get them in shape. They'll still have to work at it to be in good shape. And the other time that atrial fibrillation can cause symptoms is administrative symptoms. And I'll tell you exactly what I mean by administrative symptoms. So I walk into the exam room, come on in. Now we can start. So I walk into the exam room and I meet a patient for the first time and I say something which I think is benign, like, how you doing? And she says, how do you think I'm doing? I mean, I was fine. I was actually sitting there at a picnic and my heart goes racing. I mean, I have a family history of heart disease. So I go into the emergency room and they say you have to take this blood thinner. And then they set me up for a cardioversion. And like, I don't even know what a cardioversion is. Like, and, you know, lasted for a couple of days. And now, you know, I'm back in it. I don't even know. They said I had to see you. Now, what is interesting about that conversation, this person's life is really in turmoil. Did she mention any symptoms? No. As for all we know, if we just calm her down, all her problems will go away. Okay, but we need to explain things to patients effectively. We need to tell them this is not as bad as it sounds. So I think administrative symptoms, I think as Dr. Corsello often says, a therapeutic conversation can be worth more than the medications. So what is a tachycardia-mediated dilated cardiomyopathy? Anybody? Okay.
When your heart rate goes too fast, that your reduction in your LVF.
Did you guys all hear that? They got it.
Tag team.
Tag team. So a dilated cardiomyopathy can be due to a persistently elevated heart rate well in excess of 100 beats a minute for weeks or months. Okay. And you will see this presentation time and again. And I think it's important just to understand how it will present, because somebody will develop atrial fibrillation and not feel it. Somebody will develop atrial fibrillation and not feel it, and they don't feel it, and their EF goes to 45%, and they don't feel it. Their EF goes to 30%, and one day they can't breathe, and they go to the emergency room, and a well-meaning physician says, "Oh, you feel bad because you're in atrial fibrillation," but they're wrong. You feel bad because you're in florid heart failure. So we need to treat both. Now, there's really good news about tachymyopathy, is if it's truly tachycardia mediated, it will get better simply with controlling the heart rate effectively. In fact, it usually goes back to normal. Okay, under attribution. This only, okay, I'm going to say something really sexist. Sorry, Anthony. This under attribution only happens in men. Okay. I'll give you an example of under attribution. You ready? Okay. So a guy walks into your office and he is furious. He's angry. He's red in the face. Why is he angry? He went to get his knee operated on, and the anesthesiologist sent him home. Why did the anesthesiologist send him home? He was a new AFib and he didn't know it. And this guy is fit to be tied. He said, "You better send me back to that doctor because I feel fine. I feel fine." In that circumstance, you hope that that gentleman's wife is in the room. Because as night follows day, she will turn to you and go, but this will happen time and again. People will say, "I'm asymptomatic in my atrial fibrillation." And what they really mean is the symptoms have come on so gradually, and my inability to walk upstairs is attributed to old age or loss of ambition or the bad knee. And in fact, those people will feel better when they're in sinus rhythm. So I am very cautious when somebody says, "I don't feel my atrial fibrillation." I mean, occasionally people literally cannot tell the difference, but you have to be careful about saying people are asymptomatic. Okay, so can anybody outline rate versus rhythm control?
Rate is controlling the beats per minute rate.
Right.
And the rhythm is that what you're asking about?
Yeah, so the reason I'm asking, first of all, I'm glad you guys know, because this is the big fork in the road. This is the first big fork in the road. A guy comes in with atrial fibrillation and he expects you to treat it. He wants to get better. Comes to the wise cardiac healthcare professionals. He wants to get better. And and these choices are not irrevocable, but the first choice is, am I going to leave this person in atrial fibrillation and control their rate so that they'll be okay? Or am I going to get ambitious and try to get them back in sinus rhythm? That is a big fork in the road. And it's usually an easy decision, but sometimes it's not. It all depends on the patient. So rate control, then rapid ventricular response to atrial fibrillation, usually with medications. Rhythm control, for attempting to establish and maintain sinus rhythm. Okay? If only there had been a study that compared those two. Wouldn't that have been great?
It must have been.
Oh my God. Well, and I'm proud to say that we were an enrolling center in the Affirm trial. Okay. And what and please don't memorize this slide. The Affirm trial looked at people who were mainly elderly and had either persistent or paroxysmal atrial fibrillation. And you only had, it was pretty easy to get in. You could have one episode of AFib, 6 hours or greater. Most of them had more atrial fibrillation, but they would take all comers. But in general, they were elderly. Okay. And this is the study protocol. I want you guys to memorize this slide. This is the study protocol. Oh, there it is. Okay, this is easier. Okay, this is how I look at the study protocol. The first one I call atrial fibrillation happens. It's going to happen. Live with it. Okay, both groups were anticoagulated. Back then, the anticoagulant was Coumadin. Nobody had ever heard of it, DOAC. Okay. So anyway, so both groups were anticoagulated. That was taken off the table. In the first group, they said, you're in atrial fibrillation, live with it. We'll put you on DIL, we'll put you on metoprolol or any other rate control agent, and we will confirm that we have adequate rate control and you can live a normal life. The other one was the Iwo Jima approach. They were going to do anything they could to get somebody back to sinus rhythm. Now, at the time, during enrollment, not at the time that they initiated the study, but during enrollment, atrial fibrillation became available. It was still considered experimental. It wasn't part of this trial. So patients would get sotalol, they get cardioverted, flecainide, cardioverted. If that didn't work, they get amio, cardioverted. They would keep trying. They were doing anything they could that was available at that time to keep them in sinus rhythm. Oh my God, there was no difference. What? There was no difference between the two groups. And that's sort of, I mean, there were a lot of people who in retrospect said, yeah, I knew it all along, but we didn't. We really thought that if we could maintain sinus rhythm, people would do better. Okay. And I'm not, we'll talk about how things have changed since that time, but I think the results of the Affirm trial are still important. People who are anticoagulated with adequate rate control still do well. Okay. This was one of the most fascinating parts of it to me, and this really changed the way we look at atrial fibrillation. Most of the strokes occurred in patients in the Iwo Jima arm, the patients who we thought we'd maintain sinus rhythm. And you're going to say, how did the study protocol allow that? Well, it turns out that the only way they could enroll all those patients was they allowed anticoagulation control to be controlled locally, not centrally. So if, even though this was not recommended, if the enrolling cardiologist said, boy, this guy is doing really well on sotalol, he's not having any atrial fibrillation, I can afford to discontinue his Coumadin. Those were the people who had the most strokes. Okay. So, and I'll sit on that for a second. I'll let it percolate, because for up until then, sort of the dogma had been, if you can't anticoagulate people, just get them in sinus, they'll be okay. Or if you keep them in sinus, they don't have to be on that yucky drug anymore. That was completely wrong. That blew that out of the water. The other thing that came out was that it turns out we were not as good as we thought we were at treating atrial fibrillation. So in the Iwo Jima arm, sotalol, cardioversion, amio, cardioversion, After 3.5 years, only 60% of the people were still in sinus rhythm. And I'm being a little bit facetious. We are good at caring for atrial fibrillation, but atrial fibrillation is a formidable opponent. Okay, it is tricky to treat. It's hard.
I know you haven't.
Aggressive. Okay, so
So,
somebody's talking.
Yeah. There's background, I didn't realize that. Use them, but.
So
the form filled out.
Just a reminder to put your mic on mute for those that are participating online.
or don't put it on mute and ask a good question.
Ask a good question, yeah.
So what did we learn from rate control, rhythm control? Both work. Anticoagulation is a lifelong strategy. How often have you ever met the patient with atrial fibrillation who didn't ask you, how much longer do I need to be on this blood thinner?
I have a question
Yeah.
about that. Is when we have people through ACU
Yeah.
have AFib ablations,
Yeah.
our like post directions say, take your anticoagulation for at least 2 months, but we don't ever see them again. So do they ever get off of it or no?
There is an answer to that, and I will answer it, but I want anybody else to answer first. That's a great question.
To be determined.
Well, it depends on their CHADS VAS score, which we'll get to. So if they're at very low risk for stroke, then they need to be anticoagulated in the peri-procedure period. Did I say that right? Peri-procedure period. But they may not require lifelong anticoagulation because their stroke risk is so low. Okay. But anybody with a high CHADS VAS score, and we'll get to that, should be anticoagulated for life. But they all ask the same thing, right? When can I stop my blood thinner?
Yep.
Right. So eradication of atrial fibrillation is a big challenge. Okay. So now we're going to go through the categories of atrial fibrillation. I gave a sneak preview. Tell me the categories of atrial fibrillation. And this is actually it turns out like billers sometimes ding me if I don't put the right category. So it's important. Paroxysmal. So what is paroxysmal atrial fibrillation? You're right. Yeah, you can't make up your mind. Technically, okay, so that's paroxysmal. What is the next one? Persistent. And technically, persistent is anything longer than a week or requiring a cardioversion. Okay. The next category. What?
Permanent.
There's one between, which is almost a gray area. It's almost, well, anyway, long-standing persistent. If you've been atrial fibrillation for a year or longer, become long-standing persistent. And permanent is a weird designation. Permanent is a weird designation. Permanent means your cardiologist has given up on getting you out of atrial fibrillation. It is not a physiologic diagnosis. When we say permanent atrial fibrillation, it means that we have consigned them to a strategy of rate control.
Not to say they can never, ever go back into normal.
It's very, if your cardiologist gives up on you, it's very unlikely. It could happen.
You get a new cardiologist.
Yeah.
Yeah. So anyway, and I'm not saying that wasn't made for the right decision. I'm just saying it's not physiologic. Okay. All right. So rate versus rhythm control. Has anybody ever heard the old term AF begets AF?
Yes.
Everybody used to say it. They don't say it anymore. That's why you don't hear it. But the longer you've been in atrial fibrillation, nothing's gonna work. When did we learn that? In the 60s. In the 60s, somebody figured out that if you cardiovert people for atrial fibrillation, they were back in sinus rhythm. And everybody's like, yay, we won, we beat AFib. And soon it turned out that if people had been in atrial fibrillation for a long time, let's say a year or even longer, they were much less likely to maintain sinus rhythm. So it is in this era that is absolutely the same. The longer you have been in atrial fibrillation, the less likely any therapy will maintain sinus rhythm. Okay. And this part is important. And it's really important in the exam room when you're talking to patients. I always say there are a couple inappropriate ways to treat atrial fibrillation, but there are innumerable appropriate ways to treat atrial fibrillation. Why do I say that? Because they walk in and say, well, my cousin got a pacer and he's fine. Okay. I'm happy. You know, your cousin is a good doctor. That may not be the right therapy for you. Okay. So do not memorize these trials. In fact, you'll understand the gist right away. But these have just come out in the last several years, and they have absolutely changed the way we approach atrial fibrillation. So ECFNet demonstrated that early rhythm control actually decreases adverse outcomes. So that is, at first glance, it runs counter to the results of Affirm, which basically said rhythm rate controllers are similar, but it's not. This occurred in younger people. They basically said, as soon as we see atrial fibrillation, we will try either using antiarrhythmics or ablation to maintain sinus rhythm. Tend to be younger people, and it was very aggressive and very early. And it included ablations, which affirmed it. The next four studies basically showed that if you want to maintain sinus rhythm, ablation is both safer and more effective than antiarrhythmic agents. Okay, and I want to dwell on that for a second, because that wasn't always what we recommended. So in the early days of atrial fibrillation ablation, the guidelines said if nothing else works, you can try it. And then the guidelines evolved so that, well, you don't have to wait to fail antiarrhythmic agents. You could, if you wanted to, use ablation as a first-line agent. And now the guidelines are saying it is a good idea to try ablation before you try antiarrhythmic agents. So that's a big difference. And I think from an emotional point of view, it's really good for us to think about that, because the mindset used to, before you guys were in practice, of course, but the mindset used to be, let's do something gentle first. Let's try a little bit of drug. You know, let's not do general anesthesia with catheters in the heart. Let's do something gentle. It turns out atrial fibrillation ablation is safer. And
Perspective.
as far as hospitalization, side effects, or arrhythmia. So, looks pretty simple, right? So, there was a book which I completely disagree with the premise. It said everything I needed to learn, I learned in kindergarten. That's not true. But in this case, it is. You just connect the dots. That's all we have to do. So that is picture left atrium, and you can see, I can't remember who did it. Let's just say it was Hank. He completely encircled both sets of pulmonary veins, achieving isolation. And that is the alpha and omega of an AFib ablation. As you guys know this better than I do, but it more often than not, it's a day procedure. Yes, people spend the night in the hospital, but the majority go home the same day. It's, when I say safe, it doesn't mean they're not complications. They're just infrequent. And in a young person with a structurally normal heart, paroxysmal atrial fibrillation, the success rate is about 80%. Now, I want to dwell on success rates for a second, because this is a hot topic. And the first thing you will learn is that it's hard to agree on a definition of success. Okay, so if you do it the way we used to do it, we ablate somebody, we didn't hear from them again. We said that's successful. They're in sinus rhythm. You run them main mall, I'm still doing really well, 100%. That was the way we measured success. And our success rate was pretty good. If you do it the way we do now, we do monitors every 6 months. We do frequent EKGs. We see them more often. Success rate is going to be lower. The acid test, which we don't routinely do, is you put a loop recorder in them, and then your success rate is even lower. Okay. And the reason I'm saying that is because everybody wants to know the percentage, and it's actually a fluid thing. So I And I'll tell you a story because I think this illustrates why I don't want to dwell on the numbers. Years ago, a healthcare provider working in the OR had atrial fibrillation, and we sent him to a specialized center that did AFib ablations of the frigum. And he listened carefully to that gentleman. He came back next month later and said, "Get your ablation yet?" He said, "Yeah, I went got it at Worcester." I said, "Why?" I said, "Because they have an 85% success rate." You don't know that, you know, those are fluid numbers. You make them up as you go along. But 80% is a pretty solid number as far as freedom from symptoms in young, healthy people with structurally normal hearts and paroxysmal atrial fibrillation. Okay. Now this part is really important. There is no one antiarrhythmic medication that is universally safe. These need to be initiated, titrated, and monitored carefully. So one of the interesting things about rate control is that we know how to control the rate. We don't know what the target ought to be. So we have not yet done a multi-center dose titration trial for rate control in atrial fibrillation. So the Affirm trial said you had to have a resting heart rate of 80, an average heart rate of 100 or less on Holter. That seems pretty lax to me. And it's important to say that we've seen tachymyopathies in people with average rates as low as 110 beats a minute. It's usually faster. 110 beats per minute in general won't do it, but it could. So we don't yet know the best way to control the rate. I usually look for a target heart rate somewhere in the 80s. I think 90 or above is a little bit scary for me. So again, everybody has their favorite go-to drug. I'm not going to dissuade them, but you don't need to go to any one or the other. I will say this, digoxin does not work well as a first-line agent. Digoxin can work well in addition, sort of as a supplement to another rate control agent, but as a standalone, it's rarely effective. One of the more important things about rate control, and this is really directed to the outpatient setting, it is really important to start off with low doses and titrate upward with frequent office visits. Why is that important, guys?
Slow, start slow. You are tolerance to beta blockers, like you know.
Exactly. So if a guy comes in and he's going fast, and I say, I'm going to start you on 100 of metoprolol. Okay. He's going to take it for a couple of days, and then he's going to switch his care to Ritva. Okay. So he doesn't like that pill. And it is also true that our body upregulates beta receptors. Our body upregulates beta receptors. That's really important. So I always tell people that the first week on the beta blocker is not representative of how they're going to feel. Okay, that's really important. So let's say my doctor puts me on metoprolol, and I take a solid dose of metoprolol, and I feel awful. I can't get out of my own way, and I'm really kind of having kind of vague thoughts and stumbling a little bit. I will stop that pill because I say I can't live my life like that, unless my doctor says that's going to go away after a week. So we do need to warn them about the first week. Okay. This trial blew my mind. Has anybody ever heard of the Afib CRT mortality? Did I say mortality? The Afib CRT mortality trial. This study just came out. It blew my mind. Now, the only problem with the study, they didn't enroll a ton of patients. They only did 133, but they reached statistical significance. What they took, okay, I'm really going to jump up and down about this trial. They took people who had rate-controlled atrial fibrillation. Rate-controlled atrial fibrillation. Their heart rate was under control. They were in, quote, permanent atrial fibrillation, but they were rate-controlled. Okay. They had to have at least one hospitalization for heart failure. It could have been I forget these terms, HFpEF or HFrEF or now HFMF or whatever they call it. Anyway, they didn't have to have low ejection fractions. A lot of them did, but they has one or more hospitalizations for heart failure. They might have been fine the rest of the time. They had one or more hospitalizations for heart failure. And did I mention that their atrial fibrillation is already well controlled? Okay. So the dogma would say, leave them alone. They're fine. So they randomly assigned them to staying on usual therapy or getting AV node ablation and cardiac resynchronization therapy. Not only did they live better, not only did they feel better, not only did they have fewer hospitalizations, they lived longer. Anybody else's mind blown? Mine was. Okay, great. Okay. So cardioversion strategies. There are kind of three tried and true methods. Elective cardioversion after the demonstration of 4 consecutive weeks of therapeutic anticoagulation. Whether it's 3 or 4 is less important, but they've been well established on anticoagulation. Cardioversion within the 48 hours of the initiation of the episode in low-risk patients, i.e. Chad's VAS score of 1 or 2. Or TEE followed by cardioversion with pre and post cardioversion anticoagulation. And this part, I'll just say it a couple of times. Even if your Chad's VAS score is 0, if you've been in atrial fibrillation for longer than 48 hours, you need anticoagulation before your TEE, before your cardioversion, and for at least 6 weeks afterwards. Yeah.
6 weeks, not 30 days.
I usually say 6 weeks. For 30 days, it's probably fine. I'm just old fashioned.
If someone's presenting with their first episode of AFib, is there any improvement in getting them cardioverted with a TEE within the first 30 days? Or is there a benefit to just anticoagulating them for 30 days and then doing the cardioversion? We were talking about get them into sinus as fast as possible, but is there that much of a difference in like doing a TEE? Probably not. Okay.
Probably not. It's I mean, most patients are impatient. They don't want to wait 3 weeks, but it's probably one in the long run. It won't cause atrial remodeling.
Okay. I didn't know if it was like days, weeks, or months. Kind of.
Probably not.
Okay.
So this is more historical because I used to see this. I don't think anybody does this anymore. People with cardioversion for the first discovery of AFib. And I've seen this. People come in and they say, yeah, I got symptomatic last night. You don't know that. Okay. I had one cardiac fellow, and I can't make this stuff up. Patient came in to a non-cardiac floor, needed a blood transfusion, had a transfusion reaction, and felt terrible. Their heart was racing. It was in AFib. So the cardiac fellow said the reaction caused their atrial fibrillation. That's cardiac work. What? That person could have been in AFib for years, and their heart rate went fast when they have transfusion reaction. So first discovery is no good. Gaps in the INR record, no good. And there was a brief moment sort of in the 80s when, like, if there was no left atrial appendage, people thought it'd be okay to cardiovert and not anticoagulate. That turns out to be wrong. Most important thing about a cardioversion, tell the patient it's going to come back. What? Why am I getting a cardioversion? Well, the reasons for cardioversions can be different for each patient. But if you don't tell patients that atrial fibrillation is a progressive problem, then when they develop atrial fibrillation, they're going to jump to 1 or 2 conclusions. Okay? Either you're a crappy healthcare provider or there's just something wrong with them. Okay? Neither of those things are true. So let them know ahead of time that they're going to have a recurrence. What time is it?
48.
Okay, good. Okay, so we may fly through stroke prevention. I hope we don't. But if there's one thing I want to get across, aspirin doesn't work. Aspirin does not prevent strokes and atrial fibrillation. And fascinatingly, The original studies that demonstrated that Coumadin prevents strokes in atrial fibrillation, the control groups were all on aspirin. The people who were having strokes were all on aspirin. So how often have people said, I don't want to take that blood thinner, can I just take aspirin? So just bear that in mind. There is no other way, no other non-surgical way to prevent strokes except thrombin inhibition. You guys all know the Chad's mass square, so I'm going to fly through that. Okay. So how do we reduce stroke risk in atrial fibrillation? In addition to anticoagulation, which should be the mainstay of therapy, and there's no substitute for that. We need to treat their hypertension, hyperlipidemia. Exercise will lower the stroke rate. You can clip the atrial appendage. You could put a Watchman in there. But again, I'll just underscore this. Achieving sinus rhythm is not the way to do it. They may feel better. They may love you. But they still need anticoagulation. So are they blood thinners? Well, I don't know. Doctors call them blood thinners, pharmacists call them blood thinners. They don't thin your blood. If you look at my blood when I'm on Eliquis and you look at my blood when I'm not, it's just as thick. Okay. They don't thin out your blood. Why is that important? How many times have people told you I have to go to Florida in the winter because Dr. Costello put me on Coumadin? Okay. Because it thinned out my blood. Is that true? Because it's not a blood thinner. It didn't thin out the blood. It's an anticoagulant. Okay. They also say, ever since my blood got thin, I'm tired. Okay. Is that from the Eliquis?
No.
So these are not blood thinners. The other one is I'll bleed to death. Is that true?
Maybe. I'm from the Charles.
Very seldom. Yeah, very seldom. And in fact, even when we have the world's most dangerous thrombin inhibitor, Coumadin, all of the multi-country trials that were done in industrialized countries. And these people were getting in automobile accidents and using chainsaws and cutting bagels and
Chainsaws to bagels.
okay. And the bleeding rate, the rate of major life-threatening bleeds was so low that it was totally eclipsed by the decrease in stroke rate and death from thromboembolism. And I think that part's really, really, really important. So we talked briefly about warfarin. This is why we don't usually use warfarin. All drugs will have a therapeutic window. Okay. This is just an illustration of how tiny the therapeutic window is for warfarin. So if you look here, the minute you get below 2.0, your stroke rate goes up. As you get to about 4, your bleeding rate goes up. Okay. I'll tell you a pill that has a wide therapeutic window, azithromycin. Okay. When you have an infection and your doctor gives you Zithromax, does she check the levels? Why not? Because it has a huge therapeutic window. Okay. And the same thing is true for DOACs. The reason we're not checking DOAC levels is because it has a very wide therapeutic window. Okay. Has anybody ever prescribed Doxaban? Yeah, it's in all the charts. I don't think it's available in the US. And I'm really going to fly through these because I just want to tell you, DOACs or NOACs are more effective at preventing strokes, and they also are safer with respect to bleeding. I'm not going to talk about Watchman today. That's a different lecture. It can work. It's only in high-risk patients. Why do we talk about exercise? Well, the typical person walks in and says, you got to get rid of my atrial fibrillation. And if you time, you'll say, why should I get rid of your atrial fibrillation? You want me to make your EKG look better? You say, no, I want to lower my stroke risk, have more energy, relieve my shortness of breath, do more, live longer.
Exercise is medicine.
this can be achieved with regular exercise. Okay, so and I'll go through a couple more slides which will explain why we are required to talk about this. So lifestyle, these things are really important. Diagnosis and treatment of obstructive sleep apnea, temperance, respect to alcohol, weight loss, exercise. Each one of those things, and these are additive, can lower the likelihood of recurrent atrial fibrillation. Alcohol is really interesting. So, you know, that guy on TV was telling me a glass of wine a day is good for my heart. I honestly took that the wrong way. I was like, that too would be awesome. Okay, but I was wrong. Now, if we look at if we look at just the traditional coronary disease, people who drink moderately actually have less coronary disease than teetotalers. Okay, but it's the opposite with atrial fibrillation. People who don't drink at all have less atrial fibrillation than people who have 5 drinks a week. And I'm not going to tell people how much to drink or not to drink, but I always explain to them that the less alcohol they drink, the better it is at controlling their atrial fibrillation. So Arrest AF, fascinating study. Again, changed the way we looked at atrial fibrillation. So this was done in Australia, and you'll see why. Patients were, they enrolled patients who were, quote, undergoing ablation for atrial fibrillation. But in Australia, the average wait is 10 months. Okay. And so while they were waiting, they were offered aggressive risk factor modification. Okay. It was intense. They did home blood pressure 3 times a day, treadmill testing, office blood pressure checks, dietary advice. With weight, they were really mean. Face-to-face counseling, if they didn't lose 3% of their weight after 3 months, they actually started prescribing their meals. Yuck. Okay. Even after they lost 10% of their body weight, they were still followed to ensure they maintained high protein, low glycemic index, calorie controlled meals, and they were required to have moderate intensity exercise 200 minutes a week. Okay. That's 200 minutes a week is doable, but it's a lot less than most of us do. They were really tight with blood sugar control. Everybody underwent sleep apnea testing. Alcohol consumption, less than 3 glasses of wine a week. This is Australia. That was a big intervention. Look what happened. It turns out that the people who didn't get an ablation but adhered to a healthy lifestyle had as little atrial fibrillation as the people who got an ablation and didn't adhere to a healthy lifestyle. But they were additive. They were additive. So if you adhered to a healthy lifestyle and got an ablation, you did the best of all. So the reason I'm telling you this is in this era, if we just treat atrial fibrillation with pills and procedures, we are failing our patients. We absolutely, lifestyle is a crucial part of staying healthy. Oh, well, staying healthy anyway, I know, but especially with atrial fibrillation. So I've done a lot of talking. I hope I didn't overload you with information. This is the best time for us to ask questions.
I have questions.
All right, Kathy Mercier.
First is, how do you encourage people to exercise? Because I'm sure there's a lot of fear in exercising and making their heart rate go up. So how do you manage that?
Wow.
And the watch, the Apple Watch.
Wow. I left that one out. So, at what heart rate can you not exercise? What can people with atrial fibrillation not do? Trick question.
Yeah.
They can do anything. I mean, for example, this is a younger guy than me, but my brother, when he was having atrial fibrillation, he was still riding his bicycle up mountains and stuff like that. And his heart rate would get, at peak, would peak at say 190 and stuff like that. He didn't feel really any different. He was, quote, asymptomatic. But we don't have any data that avoiding exercise, we have very good data that avoiding exercise is really bad for you. We don't have any data that vigorous exercise is harmful. We don't have any data that vigorous exercise is harmful. Now, there is an exception, and that is elite athletes. So marathon runners, professional cyclists will actually have more AFib than people who run, say, 20 miles a week. It looks so the sweet spot is running about 20 miles a week. I'm not at risk for being an elite athlete, okay? But vigorous exercise should not be proscribed. In fact, you should encourage people to exercise as much as possible. There is nothing dangerous about exercising vigorously in atrial fibrillation.
So my second question, that's okay. How about like with the last three there, as far as ownership from the patient's part, or what can they do to help facilitate or get them to buy into the weight loss, the exercise, things like that? To me, that's, especially working in hospitals, like, oh, this is what you should do, but then.
I'm going to give you a really bad answer to that. I think it really comes down to the provider-patient relationship. So if, I'll give you an example. Do you remember Jorgensen, vascular surgeon? Kind of a severe gentleman, to say the least. Okay. He, patients would go to him with vascular disease and they had claudication. And they would come back furious. They said, he told me to stop smoking and walk. That's because he hadn't established a therapeutic relationship with them. He basically made them feel like it was their problem.
Yeah.
So it is, and there's an art to establishing a provider-patient relationship. But until they sort of say, yeah, I want to be partners with this person, I want to make it better, it's going to be really hard. And I also think it can't, in general, it's unlikely to happen with the first meeting. It's unlikely, guy comes in and, main form of exercise is grabbing the remote. And, some young, healthy APP says, you should really get up, move. They'll kind of say that they mean well, see it. So it's kind of a process. I don't think it can happen right away. All right.
So thank you very much.
Sure. Thank you. Let's see. I'm just looking to see if there's no questions on the chat.
Yeah. Yeah, no, tomorrow.
I'd love to do it again now.
Do you want to
I'm service to.
Oh, great. Yeah, that's so you'll, and then.
Yeah, it's my first day back, so.
It
It was great. Yeah, good to see you.
They want
Kids
some
and
else,
also
a lot of different, what categories needs to actually look at, so the other.
Kathy has someone else, I think.